Hi, um, my name is Sanjay Gupta. I'm a consultant cardiologist in New York. And today I thought I'd do a video on the subject of anticoagulation in atrial fibrillation. And the reason for this is that a few of you have contacted me and said, look, I have atrial fibrillation. The GP says that I need to go on blood thinning medications. And he's saying I should be on Warfarin, and I don't fancy the idea of Warfarin. Could you do a talk on the subject of Warfarin, the importance of Warfarin, and also these new agents that have now become available, which are like Warfarin and do the same job, but may not cause me the inconveniences associated with taking Warfarin? So I thought I'd do a little video on this subject, okay? So the first thing is, this relates to people who have a condition called atrial fibrillation, which is where the heart chooses to go irregular. The heart rhythm becomes irregular for a short-lived period of time or on a permanent basis. So some people have paroxysmal atrial fibrillation, where their heart can become irregular from time to time and then become regular by its own volition. Or in some people, it becomes permanent. So they have an irregular heart rhythm all the time. And we now know that about 2 to 3% of the population have atrial fibrillation, okay? And the problem with atrial fibrillation is that when the heart is beating irregularly, does not beat as strongly as when it beats regularly. And the loss of efficiency is around about 15%. So the heart is 15% less efficient when it beats irregularly. And for a lot of people, it doesn't really matter, because even the 85% that you're left with is more than enough to keep you going without a problem. But the problem is that 15% lack of efficiency means that 15% less blood comes out of the heart every time the heart beats. And therefore, that 15% of blood, which should normally be moved, doesn't get moved. And it can therefore stagnate and form a blood clot within the heart. And then there is a risk that bits of those clot can get dislodged and go to the brain and cause strokes. So the main risk with atrial fibrillation is the risk of stroke. And it is therefore recommended that if you have atrial fibrillation and the risk is deemed high enough, i.e., if you have any of the following: if you are older than 65 years, if you have high blood pressure, diabetes, structural heart disease, or ever had vascular heart disease or vascular disease, so strokes, TIAs, anything like that, then you are considered at high risk of having strokes, and therefore it is generally recommended that you should have your blood thinned by taking a blood thinning medication for life. Okay, and you need to take it for life, because the risk goes up with age, and therefore the risk can only ever go up. A lot of people ask me, okay, so that's fine. Is there any other risk? And the answer is no. It's mainly the risk of stroke. Then people say, well, in terms of blood thinning medication, what about aspirin? I take aspirin a day. Aspirin has no role. Aspirin is not a strong enough blood thinning medication for this condition. It will not prevent your risks of stroke, and therefore you might as well not take anything if you're going to take aspirin, because aspirin will predispose you to the risk of ulcers, etc., and not give you any benefit. So if it's a choice between aspirin and nothing, I would take nothing. But I really, really recommend that if your risks are deemed high enough by your cardiologist or by your GP, that you start on some blood thinning medication. And you will need to take that blood thinning medication for life. So it's a big commitment, taking a blood thinning medication for life. And most people say then, well, what is the risk associated with taking blood thinning medication? And the big risk associated with taking blood thinning medication is that it thins your blood, so you're more likely to bleed. If you cut yourself, you're more likely to bleed. If you're unfortunate and you have, a propensity in your brain or in your gut, you could bleed within your head or in your gut. The risks are generally small, and when you're considered high risk in general, if you have no pre-existing problems that increase your risk of bleeding, then mostly the benefits of preventing a stroke outweigh the risks of bleeding. But your doctor will decide, having evaluated you, whether your bleeding risks are high enough to contraindicate taking blood thinning medications, or whether in fact your stroke risks are so high that you should take your blood thinning medications regardless. Then the next question is, what are the options for blood thinning medication? Well, until very recently, there was really only one agent, warfarin, which people used to be given for this. And warfarin is essentially rat poison, and it thins the blood. The problem with warfarin is that it requires very regular monitoring. So you have to take the warfarin, you have to get some bloods checked and work out whether the warfarin is thinning your blood adequately. And that blood test is called the INR. And we normally say that you should, if you have atrial fibrillation, have an INR of between 2 and 3. If you're not on anything, your INR would be about 1. So what tends to happen is people get started on warfarin, they then have to come and have a blood test, and they get an INR value, say they take some warfarin, they have an INR value of 1.2, then they come back, they're given more warfarin, then they go and have another blood test, and the aim is to try and get the dose so that the INR bit remains between 2 and 3. Any more than 3, there is a higher risk of bleeding. Any less than 2, there's a higher risk of stroke. So you need to be within that 2 to 3 mark, and this requires regular blood tests. And on average, I would say you would require between 8 and 11 blood tests on a weekly or twice weekly interval to get within that range, which means approximately 8 to 11 visits to hospital to have blood tests. And this obviously poses a great degree of inconvenience for patients. You know, for a lot of people who are elderly, who are not easily mobile, it's a big undertaking to come to hospital 11 times and have 11 blood tests. The other problem with warfarin is that it can interact with several other agents. It can interact with drugs, and therefore sometimes it can depend on what you're eating and what other drugs you're taking, and that can interfere with the blood thinning ability of warfarin, and you might find that the INRs vary. So that's why people have not been traditionally very happy with taking warfarin. But there's no doubt that if the blood is kept nice and thin and kept within that range of 2 and 3, it's as good as any other agent we have. More recently, and driven by this need to have something more convenient, there has been the development of a newer class of drug called the NOACs. And that means the novel oral anticoagulant agents. And currently there are 3 main NOACs available in the market. And these include dabigatran, or Pradaxa, which was the first one to be developed. And then there are 2 others called rivaroxaban and apixaban. And they all work in slightly different ways, but they all have an effect on the blood, on the thinness of the blood. The main advantage of the NOACs is that you can just take them as tablets, and you don't have to have regular blood tests. So you don't have to come to a hospital, get your blood test. You just take the tablet, and the tablet thins your blood. Is there any evidence that they work? Yes, there is plenty of evidence. All 3 agents have been studied in several thousand patients, and in total over 50,000 patients have been studied, and the NOACs have been found to be in general as effective as warfarin, at least, and in some cases even more effective than warfarin in terms of preventing strokes. There are a few concerns that have been raised by people about the use of NOACs. Of course, they are relatively new drugs, so they're not as tried and tested as warfarin. Secondly, a lot of people argue, well, how do we know that they're working? That's true. You can't, you don't have a blood test that you can use to monitor whether they're working or not, but we know from big trials that they do work. And remember, we take lots of other tablets and we just take them blind faith. We don't know whether, we don't go and, we don't go and have a blood test every time we take a beta blocker to see whether that beta blocker is working or not. We don't, we don't take we don't go and have a paracetamol test every time we get a headache because we want to know whether that paracetamol is working or not. So it's not just because we are used to having an agent where we required regular blood tests doesn't mean that if you can't, or if you don't have a way to monitor things, that if agent is less efficient in any way. We have enough trial data to support the use of NOACs in this setting. The second thing to say is that a lot of people talk about antidotes. Okay, warfarin has an antidote. So if you start bleeding excessively from warfarin, then you can come and someone will give you a vitamin K injection, and that will reverse the effects of the warfarin. NOACs at the moment don't have an antidote. And a lot of people get very worried about, the fact that there's no antidote. So, oh God, it'd be awful if I bled and I could bleed to death. Yes, of course, there's no antidote, and that obviously the concern is not unreasonable. But let's think for a little while as to what happens if you bleed. Well, there are two main places where you could bleed from seriously. You can bleed from anywhere, but generally most sources of blood loss are easily controllable. But there are two areas where you can bleed from in a life-threatening manner. And the first is the head, so you can bleed within the brain, and that can be very dangerous. Or the second is the gastrointestinal tract, or the bowel. The difference between them is that the bowel is accessible and you require a lot of blood loss to become very unwell. So, if you bleed from the gut, you have to bleed quite a bit, you become unwell, and the bowel is accessible. Someone can put a tube down and find where you're bleeding from, or a tube up the back passage and find where you're bleeding from and sort it out that way. The brain is different, because it's not accessible, and you only require a very small amount of blood loss or bleeding within the brain to cause death. So it's important to bear that distinction in mind. And then when we look at the trial data, when we look at those 50,000 patients that have been studied in all the studies, we find that the NOACs are associated with less bleeding within the brain compared to warfarin. Okay, but probably equivalent amounts of bleeding in the gastrointestinal tract compared to warfarin. Because the amount of blood loss that is required to cause death or significant disability in the brain is so small, having an antidote really doesn't make a huge amount of difference, because if you were unfortunate enough to bleed within the head, then only a small amount of blood loss, and that's it. You're not going to find that you can come into hospital, get an antidote, and that will really make a difference to your outcome. If you're unlucky enough to bleed in the head, that's it. I personally would rather take an agent that is less likely to make me bleed in the head compared to, rather than take something which is more likely to make me bleed in the head, but there is an antidote available. And therefore, I tend to favor NOACs in that setting because they cause less bleeding. The analogy is the same. You can cross a bridge where you're more likely, you can cross a bridge where you're more likely to fall off and hope that if you fall, there'll be an ambulance waiting for you and take you to hospital where you can get an antidote. Or would you rather just cross a bridge that you're less likely to fall off in the first place? And that's why I don't think this antidote argument really works for NOACs. The final thing to say is that there is a worry about perceived cost. Okay, people don't like to prescribe NOACs because people don't like to prescribe NOACs because they think that they're expensive. But they're actually only taking into consideration the cost of the drug. They don't take into account the cost of traveling for the patient. So the patient has to travel 10, 11 times, just to have the blood test. They don't take into account the personnel that are required to do the blood. They're not taking into account how it affects the quality of life of the patient. So to my mind, I think it's really important to be aware of these things when you decide what agent you go on to. If my family member had a problem with atrial fibrillation and they had to choose, I would definitely recommend a NOAC over and above warfarin. The final thing to say is that there are certain patients who can't have NOACs, okay? Number one, if you have an artificial heart valve, a metallic heart valve, then you should not take a NOAC because NOACs have been shown to be more harmful in that setting. Number two, if you have rheumatic mitral stenosis, then you should not take a NOAC because the stroke risks are so much higher in this condition. And thirdly, if you have bad kidneys and kidney failure, then it is recommended that you do not take NOACs in this setting. Otherwise, it's important to realize that they start working within 3 hours of taking them. You achieve immediate anticoagulation rather than waiting for months for your INR to normalize. And they work out of your system within a few hours, so the half-lives are short. So if you did bleed, you stop taking the NOAC, and within a half a day, it'll be out of your system. So I hope this goes in some way into alleviating people's questions and anxieties about the NOACs. My name is Sanjay Gupta. You can get in touch with me on my website, yourcardiology.co.uk. If you wanted to talk to me, you can do so via my secretary on the telephone number I've listed below. You can also get in touch with me through Twitter and Facebook. So I hope this helps. Thank you so much for listening, and good night.